questions on neuro from last week. The one thing I want to say is, we kind of left and it was kind of Debbie Downer because all these neuro diseases are not fun, right? I don't think I know any single one that's fun. And I guess I want your takeaway to be, it's not going to be fun for any of them. And in a way, this is our chance to make a difference for that patient, though. Because maybe you can make it this much better, just this much better, or you can help give them some coping skills. You can help teach them things to deal with these disease processes to make it easier. Maybe you can get them the right resource they're going to need so that they can do better. So, as tough as these diseases are, I want you to realize that this is your chance to make a difference. Okay? And that's what we do every day as nurses. And when we go home from the end of our day, it's kind of like, did I make a difference? And if you know you made a difference, then that's huge. And it doesn't have to be huge differences, but you come back and then later you run into these people. They're like, you were my nurse. You took care of this. You taught me this. You helped me with this. Or you be standing in the grocery store line and you're talking to somebody, and especially if somebody has a head injury or something, they're like, are you a nurse? Yes. Do you work at St. Clair? Yes, I do. You took care of me when I couldn't answer you back, but they recognized the voice. So you don't ever know what kind of impact you're going to have on somebody. I'm excited about this. There's going to be a neuro review this Friday. Everybody can write that down. Location is room 201, right here. Time is 8 to 9 o'clock this Friday. And that's put on by Michelle Harper. Okay? So 8 to 9 this Friday is an additional neuro review. So I think you might find that very helpful. Okay, questions on what we had talked about before. About MS, about ALS, about Huntington's chorea. Does anybody know what the normal intracranial pressure is? I'm sorry? 10 to 15. Yep, 10 to 15. I think you're going to want to know that. Another thing you might want to review is Babinski's reflex. Because when we talk about, remember I said we had the cerebral posturing and we had the corticate posturing. When you're bringing it in central to the core, keep that in mind. Those are things you're going to want to know. So look over this here. But spinal cord injuries are very, very tough. What did we learn about ALS? It is 100% fatal, right? And that we have that muscle just atrophies. Muscle atrophies. You want to make sure you have that. If we know that there's a spinal cord injury at T5, okay, thoracic 5, what would we expect below that? Paralysis, yep. And decreased mobility, paralysis, but sensory too. Okay, what if we're doing the neuro exam and we talked about, pointing like this, doing the different fields. What if we're actually doing the pinpoints on the neuro exam and we're taking, can I use you, Avery, as an example? Mm-hmm. Okay, so I have a pencil here. Okay, got 2 pencils here. 2, and you're not going to use a pencil here because we don't want to give her any lead or anything. But I've got 2 sharp points. Can you feel this sharp point? And that would be, can you feel the sharp point? Can you feel the dull point? But you're going to have a different instrument. So then can you close your eyes and tell me what you feel? Just go ahead and put your arms, just let them sit. Okay? And what did you feel?
Sharp and dull.
Sharp and dull. You know what? Open your eyes. It was supposedly a sharp end, but it's very dull. She was very good on her perception. She had it. But yeah, and then can you point to where you felt those? But you're going to do each side, you're going to do them together if you can. So kind of keep that part in mind. Trying to think of anything else. The autonomic dysreflexia, that's the one that's life-threatening, and it happens very quickly. That's the one where, with that spinal cord injury, all of a sudden they're going to get flushed, their blood pressure is going to go up, and you're going to need to, if there's any constriction at all, the bladder and bowel, it's all pressing. You want to loosen their clothes, you want to keep their blood pressure the best you can, use the meds you have, because that one they can go bad, quick, fast, in a hurry.
What does that happen?
Autonomic Dysreflexia, page 880 at the bottom corner. It's got all the information there on that one. So things that, I just want you to really be aware of. All right. Any other questions from this last week? That's in the new book. I don't have an old book. I apologize. I can show you what it looks like and see if you have something similar. The one
at the bottom of page 80 in the new book.
Does anybody have the old book? You need to see what it looks like. You got the new? Do you guys have it? Okay. Everything with that, though, it's sudden for these people. So I want to make sure you know that. Because I was going over. All right. Can we go ahead and start with lumbosacral low back pain? Anybody in here ever had low back pain? Yeah. It's the most common, right? The most common between the fourth and fifth lumbar space is where we have the most problems. And how fun is low back pain? It's not, because it affects almost everything you do. Our lumbar area of the spine is our most flexible. If somebody has acute back pain, it's self-limiting, less than 4 weeks. Subacute back pain is 4 to 12 weeks. And chronic persistent back pain is 12 weeks or 3 months or more. Okay, and a lot of things happen with people with back pain. They learn either how to deal with it, they learn how to take better care of their health, but it's something that's going to be persistent. And this is where you can see here that nucleus is pressing on the spinal nerve. This here's our normal, but here, sorry if you guys can see the herniation goes out and it's pressing on that spinal cord. And which one do you hear that it presses on the most for sciatica? Okay, and where does that one go down? Down your butt cheek and on down the leg, right? And it may be, depending on how it's compressed, it may be the front of the leg, maybe the back of the leg. It may go to the calf. And I can tell you that's where mine ends up usually. And it felt like a dog was just biting and clenched on the back of my right calf. I have had herniated disc, L3, L4, L5. Doing yard work, it was not fun. How do people herniate their disc? What do they have to do that?
Bad posture.
It could be bad posture. Carrying something heavy, lifting something heavy. You can open a refrigerator door. It can go out. It can be, you can cough, and then all of a sudden you have this horrible, horrible back pain. But I mean, seriously, and when it goes, well, it can go and go fast. So when it's pressing on that sciatic nerve, burning, stabbing, lower leg and foot pain, muscle spasms, can be numbness, it can be tingling. Okay, the issue with that is we're using motory and sensory fibers both. Okay, so not only is it going to affect their function, as after my daughter, I walked like this for 2 years with brace, and I could not lift up my right foot. So that's my motor, right? But sensory, what was I sensing? I was sensing pain. So remember, this can be motor and sensory. All right, how does this affect the bowel and bladder? Anybody know? Herniation L4, L5. It can cause bladder incontinence and bowel incontinence, or it can cause retention, both. So somebody's hurt their back, they came to the ER, they're hurting, they're in horrible pain, and then, what do they do? They had a bowel movement on their stretcher, like, really? Come on, why do I need to clean this up? Well, first of all, it is our job. We need to make the patient comfortable. Did they do it on purpose? Not necessarily. Not at all. But that's going to be a big thing to report to the physician because, I mean, they need to know that that function is impaired depending on the nerves. And there's big time stuff to give to the neurologist. Okay. All right. Health promotion and maintenance. Now you were touching on this, Brenda, and you were correct. So what kind of things we need? We need to watch your weight. We need to have good posture. Okay, good posture, and what's the one thing that you need to do if you can, or if you have back pain, this is also great. Pull in those stomach muscles. Pull it in, pull in your core. Is the main thing you're going to exercise for and do is strengthen that core. Okay? Ergonomics. So, I have been known when I was in terrible shape with a lot of pain to take my big ball, an exercise ball. You might have seen some chairs like that, but I just take my ball and I sit on my ball because I did a lot of stuff for physical therapy. I mean, I'm so used to the ball and getting my balance stuff done and using my core that I'd be teaching piano, I'd be teaching a lesson, and I'd be sitting on this ball, tapping with them, and I could breastfeed a baby at the same time and just but just using that ball makes a big difference when I have severe back pain. I go to that because what's it going to do, that spine? It's going to relax it and give it a little motion instead of it just being able to tense up. So you might see different chairs, things like that for in the office. So there's different equipment. People that have severe back pain, have you seen like a pincher grabber? You've got the handle up here, long extension down at the bottom. Then if they can't reach down and pick it up, okay, then they can use a grabber. So with this, all of neuro, there's going to be a lot of things that there's devices that can help. Let's talk a little bit about who does lower back pain typically affect? Do we know?
Older men.
It does affect men.
Pregnant women.
Pregnant women. Bam. That's right as she started off. And that's why I said for 2 years after I had my daughter, I really had problems. It's more in females than men, and it's usually in people between their 30s and 60s because they're the ones lifting the heavy objects or a motor vehicle accident. And they may be doing a repetitive motions can cause this flexion and extension, hyperflexion, hyperextension, with or without rotation. A lot of people will do things because they were lifting and twisting and turning at the same time. There is a thing called spinal stenosis, and this is for those old people over 50, like me. Okay? It's narrowing of the spinal canal. And the nerve root canals are intervertebral foramen. So it's going to pinch because the hole is getting narrowed. Okay? So that'll cause issues. What is the congenital spine curvature disease? What's that one called? Scoliosis. Okay. Okay. What are we going to do for these people? Positioning is key in the hospital to try to get them relief. A lot of times it's on the side and the affected side. A lot of times I'm going to be laying on my side, and it's best to let the weight of one hip fall over on the other. And what it does is it's just going to stretch this and get that pressure off the sciatic nerve. Does that make sense to you? So you're going to lay, a lot of times laying on a side, one knee over, and let that hang, and the weight of that limb will make a difference. What did I do? What did I do? Can I do this? It's like an Apple product?
The computer says you get smarter.
That's why.
Thank you. How do I get it smaller? It's a real smart board, smarter than me, that's for certain.
If you wave your mouse
Out.
Go back out of
Do
it.
this on the smart.
Do this on the screen?
Yeah,
Like an iPhone?
Like my iPhone?
Yeah.
Okay. No.
Try on it. Try it on it.
Tap.
Tap it twice. Yep.
See, thank you for teaching me. I appreciate it, because I'm like, oh my goodness, what happened here? Okay, so positioning, I gotta make sure this is out here. Okay, drug therapy, what kind of drugs are we gonna give these people? I'm sorry?
Pain relievers.
Pain relievers, but we don't want to give them anything addicting, right? So a lot of times they will take non-steroidal anti-inflammatories, which will help decrease the swelling. You can use heat therapy on a regular basis. I won't buy a car I buy them for my brother because he's in the car business, but I won't buy a car without a heated seat. It can be 110 degrees outside. I'll put that AC on, but I'm going to have my heated seat. Because especially I was used to driving 30, 35 miles minimum to my job always. And that's just therapy. It's therapy every time. Speaking about driving, that is one of the most uncomfortable things for somebody with low back pain. Cruise control is their friend. So it really, really interferes. And the other part of this, I had a neighbor that just had to have surgery and back surgery. And we're recouping as we're walking in the neighborhood. But the muscle weakness and atrophy, you can actually look at her leg, because she's dealt with this for 6 months until they just put in a bunch of cages and stuff. But her leg, you can actually see that it's smaller. And she'll get tired because that's the area of those muscles that atrophy so much. Okay? So that can happen because you're not using it like you normally would. And the other one takes over the workload. All right. And there's a lot of pain with this. I'm going to talk about the pain with it sometimes causes frequent sadness, and these people consider suicide. Any of these things with a lot of pain or to alter your lifestyle so much. Weight control, they would prefer we be within 10% of our ideal body weight. Complementary and alternative therapies, what do you think we can do to make these people comfortable?
Massage.
Massage is our key. Sunday, bam. I love massage. Massages are good. Stretching. Maybe they like essential oils. And if something like that relaxes them, anything that can help them relax. Maybe lavender, those type of things.
Do you know if massage is covered under insurance, if it's like hospital related or... I haven't found that.
Sometimes, but very few. But it is definitely worth checking into if you need that. But
I think
yes,
it should be.
I agree. I think it should be. Most definitely. Let's put it this way. My daughter has some big issues at avoiding surgery from all this continuous playing. She's got thoracic outlet syndrome, actually. And to avoid that, she is, of course, doing all her physical therapy and has for the last year. And she does all those exercises. But for the same price as what insurance pays and what I have to pay co-payment for PT, I can get her a massage every month. So last year for Christmas, that was one of her presents. Here's your Massage Envy membership. And so I totally believe in massage to get things relaxed. One of the other things people can do is a TENS unit. Have you heard of that, a TENS unit? TENS, and that stands for Transcutaneous Electrical Nerve Stimulation. All right, other things you can think of is alternative therapies. All right, let's talk about the surgeries we do for this. Now, I want you to keep in mind, so who do you think does the surgery? What kind of doctor are we looking for? Neurologist, a neurosurgeon, or we have this at St. Mary's. What kind of surgeon does the back surgeries? Orthopedic. And it depends on what type of surgery they're doing. What is the injury? What do we need? Okay, so it can be done by both. The minimally invasive ones, percutaneously lumbar discectomy. So they can go in with a little robot, go in and take part of that disc out. The thermodiscectomy, so they're shrinking it with heat. So they'll shrink it before they remove it. The laser assisted, those a lot of times they go in through your umbilicus, your belly button, okay, and then they can go through in that direction. Things we have to think about for those patients, we have to think about the risks of infection and nerve root injury. So these people, typically it's an outpatient surgery or one overnight, and they're out of the hospital. So what do you think when we have that patient for a very short time, what is really most important? I'm sorry? I think you said it. Patient education. Patient education is huge because they're only there for a short time. And does surgery fix everything? No, we have to heal from it correctly, and we still have to do the right things. The things we already talked about, of course, our diet or exercise, but how do we move them? You know, what kind of things they can do for pain relief. We don't want to get them addicted to any kind of medications to do the right thing. When is it okay to shower after you've had this? You know, do we have bandages on? Those kind of things after surgery you have to be aware of. All right, so if the disc is pressing on the spinal cord, these are our conventional surgical procedures. Our discectomy, a laminectomy, so we take out this, take out the lumen part. Spinal fusion, that's what we do after repeated laminectomies. So they'll actually fuse them together. And so they're going to use other bone material. Where do they get that bone? Ground up bone that they're using. It's like a powder. I'm sorry? Cadavers, correct. Has anybody ever been to a cadaver lab or a transplant? Yes. When you take Missouri Transplant Network comes in and they'll take a patient that has been brain dead and they're going to go and remove all their organs and things. Did you ever see the bones from a patient? They about the size of the computer screen here, or this outside here. It is like a big old Ziploc bag, and it was bones, filled with bones. All the human body's bones could fit in. They didn't like my humor. Everybody's real serious, and they pulled it out of this freezer. And so here's all the bones. And I said, that's a bag of bones. They were like, they just looked at me. I'm like, oops. But yeah, they were very, very serious. But yes, all the bones of the human body can fit in a bag like that. And they grind up that bone. And so they will use it in spine surgeries. They use it a lot of times in ear surgeries. When they have to reconstruct things, just know that cadaver bone is used a lot. All right. Here we go. We were talking about post-operative care. What is the thing that a lot of your spine patients will notice? If things go well, what do they notice immediately? No pain. Really no pain. They're doing much, much better. Okay? So that is huge. We're going to prevent our complications. We're going to do our neuro assessment, head to toe. Vital signs, which are very important. If they can urinate, why did we say it's important to be able to urinate and not have urinary retention? L5 sitting there. If they have L4 and L5 is urine and bowel problems. Pain control, we do want to keep their pain under control because we want them to move. want them to get back to normal lifestyle. And if they stay stiff or stay in bed, they're not going to be able to go home and then just stay stiff and stay in bed and not do anything. So we do want them to have their pain controlled and get up and move. Wound care, we need to keep those dressings dry. Okay? We usually don't let these patients bathe. Why do we not want them in a bathtub? That water is stationary. Okay? And so the bacteria in the water. But if you're in a shower, the water is continuously coming down and it should be clean. Okay. We want to make sure if they do a CSF check, what color do we want the fluid? Clear. And then if there were trouble with their cerebral spinal fluid, we would keep their head of the bed down if there was an issue. Keep them on bed rest. That doesn't happen very often. What kind of movement do we typically give the patients that have had, like, the cages all put in their back and the lots of intervention? Do we just say, oh, just sit up here and go, what kind of movement do we have? Log rolling. So we roll them as one unit when they're in their bed, and we help them roll. And then if they have to get up, we move and direct up, but we keep them as stable as we can for the beginning part. All right, we do want our back patients up the day of the surgery, and we get them up and walk them to the bathroom. It's very important we get them up and get them moving. One of the things that we're avoiding is a VTE. We have VTE protocols at the hospital. What is a VTE? Anybody know? Venous thromboembolism. So do we want them to throw a clot after surgery if they've not been getting out of bed? Not at all. So we want to avoid a VTE. Now there's a piece of equipment that we use at the hospital that helps with that. Actually, there's two. One's used more than others now, and it's a basic protocol for hospitals that we have to have. Anybody know what that is?
They go on the legs.
They go on the legs.
Thank you.
SCDs. What's that stand for? Sequential compression device. So typically, so they can have them up to the knees, and they can have them up to the thighs. And the main thing is you have to get the right fit, so it's not like popping off. And then you've got the tubes, and where do the tubes go to? Where are the SCDs? The pump and the machine at the bottom of the bed. And if you explain to your patient that they need these on, unless they're extremely irritable, typically, this is your massage you're getting here. It's included in the cost. It's not extra. But you do your best to help them enjoy what they can instead of just, I'm confined here and I have to have these things on. Oh, this is help you, and the way you speak and coach your patient and encourage them and listen to them is going to make a big difference to them and how they feel like they're cared for. Doesn't matter that you had a code in the previous room, but if you go to cuff it in, yeah, and what do you need now? How are they going to feel valued? They're not going to feel valued at all. But hey, I'm here to help. What can I help you with? Regardless, if you're still out of breath from taking care of the other and doing CPR. Okay? So they need to know that your approach is good. There is something called an FBSS, and that is a failed back surgery syndrome. Okay? Failed back surgery syndrome. And I want you to know that these are people with organic, psychological, and many times socioeconomic issues. Their back's not better. Sometimes they don't really want it to get better. Okay? And a lot of times they will end up with a spinal cord stimulator. They are not the only ones, but that is typically what ends up being the treatment for them. We talked about what we have to teach them, how they're going to manage at home. Do they have the right resources? Do they have somebody to pick up their meds from the pharmacy before they get home? If they're at St. Mary's, they can get their meds right there from the pharmacy there. There's different resources at different hospitals that you'll work. Do they have somebody to help with meals and that at first, or are they going to be doing all of it? Do they have support from their church? Okay, cervical neck pain. That is not a fun one either. Okay? Cervical neck pain is most commonly the 5th and 6th cervical disc. These people can also have bone spurs from arthritis in their neck. Things we do to help them at first if there is a quick injury is the soft collar. And they can wear a soft collar for a while. They just had a car accident. But you don't ever want it to go over 10 days. That'll cause decreased strength and decreased range of motion. Now, when we were talking lumbar, we were talking mostly, it could be orthopedic or neurosurgeon, right? The surgical management of the neck is a little bit different. Typically, it's a neurosurgeon. Okay? And if they have an anterior, so anterior approach of the cervical, they're going to take the disc out. They will need to be fitted for their neck brace prior to surgery. You know, as you're having that patient fill out the different surgical consents, and everything has to be put on there exactly as the doctor ordered, spelled correctly, can't have a misspelled word or anything on that consent form that you're having the patient sign, or it'll be rejected and sent back, or not hold up in court legally if we don't have it. But at the same time as you're the nurse prepping them to go to surgery, you need to make sure there's not any orders for any kind of brace for the body anywhere, or anything that they need as post-op equipment that they need to have ahead of time, because some of it you may have to need to know. What size shoe do you wear, Avery? You know? So it's a female and she needs a size 7. Okay? So we need a female size 7, but it needs to be the left foot. Or was the surgery on the right? You got to have the right side surgery. You know, different things like that. You have to have ordered and ready to go. One of the things that they will do on these patients is an EMG. Now, we talked about that the other day. Does anybody remember what an EMG, when they're testing the nerves, what it's called? Electromyography, and that's when they're checking the nerve conduction. So they will do that on a lot of these people with the cervical neck pain. All right. Okay. You've got your case studies here. Who wants to read the first one for me? Nice and loud, like you're awake. You guys are doing pretty well, though.
I can read it.
You got it, Avery? Thank you.
A 19-year-old man who was involved in a motor vehicle accident is brought to the ED. The patient was stopped at a red light when he was hit from behind by another vehicle traveling at 15 miles per hour. The patient was placed in a cervical immobilizer by the paramedics. He is alert and oriented, states that his neck hurts, and he is in no apparent distress. He currently rates his neck pain at 5 on a 0 to 10 scale, which assessment would the nurse perform first.
And what's our answer here? Airway. Okay. Absolutely. So he comes in and he's not happy. He's in that neck brace, right? All right. Let's go to the next one. Okay. While the patient is monitored in the emergency department, which finding will the nurse immediately report to the provider? The unresolved headache, the blood pressure of 90/70, so that's a little soft, but that's not horrible. Neck pain of 5 on a 0 to 10 scale. Well, after having an accident, do you think we'd have neck pain? You betcha. Increase in the Glasgow Coma Scale score. A, yes. We want our Glasgow Coma score to be high, right? So that's the opposite way, but an unresolved headache. Yes, Michaela? B. The answer is B. It's soft, isn't it? So they say the answer is B. Does it have any rationale? I can't hear you. I'm sorry.
Low systolic blood pressure can indicate a decrease in perfusion in the spinal cord.
So we have to have enough pressure to make sure that we're getting the perfusion of the blood to the spinal cord.
I know that's low, but like some people's blood pressure is that low, so how can you
Correct.
assume, like I know that's low, but
It also says with the headache, it just may be lingering from the injury.
Could be lingering. And as we get into other things today, you're going to be looking, that headache is also another symptom you're going to be aware of. I agree with you that a lot of people, we can consider that a soft blood pressure, 90/70. We're going to talk later today about how we need to make sure we have enough blood for perfusion, enough pressure.
so
Yes.
I have a question. I'm sorry.
Yeah.
So could it? Okay, so since the answer is B, could it be like okay in the previous, since we're on the previous question, if he was traveling and hit somebody from behind at 2 miles per hour, wouldn't your blood pressure kind of like spike up like because of like the adrenaline and like the rush? And, like, you kind of
You
like
would think it would have been
freak out,
higher.
Yeah.
Yes.
So I think
But-
like she said, because when she said like the unresolved headache could be lingering, and then she said maybe like your blood, you would think their blood pressure would be kind of higher because of
A little bit higher.
Yeah.
And typically, I don't mean this bad, but typically it's higher in males. Females are usually have a lower blood pressure in young ages. Okay. So yes, so we're going to go. You have to maintain their blood pressure. That's what we're definitely going to let them know. All right, our next one. Who wants to read this one?
I can read it.
Okay.
While the patient is monitored in the ED, which findings will the nurse...
Wait a minute.
Oh,
Next
sorry.
one.
Sorry. The patient is admitted to the orthopedic unit. On assessment, the nurse notes that the patient has loss of motor function, pain and temperature sensation below the level of injury. Sensations of touch, position, and vibration are intact. Which spinal cord syndrome is the nurse suspect?
Hey, what are you thinking? Okay, loss of motor function, pain, and temperature. Okay, so can't feel hot and cold. Doesn't have pain there. But he can't, let's just say he can't move his legs. Can't move them, they don't hurt, and he can't feel hot or cold. But he could still feel you rest your hand on it. He could still feel you touch it. And he could still feel if there was something vibrating. So he still has sensation, doesn't have motor function. He does not have motor function, but has sensation, right? So what are we thinking? Michaela, what do you think? Posterior cord syndrome, is that what that computer tells you? Which one does it tell you? B, anterior cord syndrome. Okay, so that weight is just sitting on that front portion of our cord. Anterior cord syndrome. The next morning, nurse's notes say his heart rate is 48 and blood pressure is 78/66. Skin is warm and dry. Now, I don't like that blood pressure. If he's 19, I can see the heart rate of 48, but I surely don't like that blood pressure. Okay, what is the nurse's best first action? A, notify. B, raise the head of the bed to 45 degrees. C, apply oxygen at 2 liters. D, increase the IV rate from 50 to 75. What's our number one answer? Because I would most likely do almost all those, right? But what's the most important?
Call the doctor.
I'm sorry?
Call the doctor.
Call the doctor so he's aware in case he wants to get there, in case he wants to get extra help, in case he wants to call a rapid response. Is A the correct answer on the computer? Yay. Okay. Apply oxygen. That's not a bad thing, but we also don't have the information on here to see whether or not his O2 sat was low, okay? But oxygen typically doesn't help unless you go way too high. We don't want to put 2 liters. Okay, D, increase the IV rate from 50 to 75. What reason would we want to increase our IV fluids? Look at that blood pressure. Typically, a blood pressure that low, one of the things you're going to do is increase their fluids. We need to get that blood pressure back up. And we can do it by expanding the volume. Okay? What kind of, if we want to do a volume expander of fluid and electrolytes, which one would you give? What kind of fluid and electrolyte would you give to be a volume expander? There's 2. What kind of IV bag? I'm sorry, I didn't hear. I'm going to just go for it. Normal saline and lactated ringers. And typically after surgery, which one do they get with surgery? Lactated ringers. Okay? All right, 10 days later, patient's going to be discharged to rehab. Okay. The nurse understands which to be realistic initial priorities of care during rehab. So you may not be working in the hospital when you first get out of here. You may be working in an LTAC. Okay? Select all that apply. Teaching self-care skills, working on mobility skills, bowel and bladder retraining, returning to pre-injury status, and training caregivers to take over patients' care. Anything in there look like it wouldn't apply? D, returning to pre-injury status. We would like that to be a goal, but realistically, is that going to be something depending on the injury? You know? What does your computer say the answer is? Go ahead, one more time real loud. A, B, and C. They got to do most things for themselves. That's going to help them. Last week, the previous week in clinical, we had a man that needed, a straight calf? And he had no intentions of doing it. He wasn't going to do it. But we did help him, and he was able to get it accomplished. And with more and more training, you can get that patient there, but you have to really encourage him. B, working on mobility skills. Yes, to do his best, he needs to be working on mobility. And like I said before, bowel and bladder retraining, because it's lower, we talked about L5, L4, L5 for bowel and bladder, and this was T, right? The thoracic injury. So you will have to work on that. He's not going to get to D. And right now, we're working really hard to get that patient trained, not necessarily all his caregivers. If they're there, they can be involved, but they can't do it for him. He needs to do it for himself. Okay. You got a patient with low back pain. Which priority assessment question or statement will the nurse provide? What is our best one? C? I like C because it's asking them about the back pain. Like the first one says just the duration. But if you ask them to tell you about your pain, that can include the duration. And what interventions, what are helpful at this point? What's say the correct answer is? C? Sweet. Because interventions, what are they doing to help it, is also going to affect their activities of daily living. That's going to be explained in there, because if there's something that they cannot do, that'll come out as well. And it's nice to know later on if they had an MRI, but that's not going to help the pain. It's going to give them more of a definitive diagnosis, right? But that's not what we have to have. Okay, question 2. The nurse understands which of the following is the risk factor associated with the development of multiple sclerosis. Is it smoking, high-fat diet, age greater than 70, or gender? Talked about MS. I gave you an example of my cousin and her daughter that also has it genetically. My answer is gender. What's it say?
Yep, D. Gender.
And it usually happens when they're younger, usually in their 40s. So, and like I said, my cousin had it right after she had her baby. Okay, it doesn't have anything to do with diet, and I don't think they've linked any of it to smoking. So, multiple sclerosis, mostly in ladies. What other symptoms are we going to have with multiple sclerosis? What problems are these patients going to have? It can be detected on a CAT scan at first. You could be going for something else, and then they might see these spots, and they're like, you've got this disease process starting. They can get a neurogenic bladder. We talked about that. They can have a lot of UTIs. They may have to do some self-cath themselves. Okay. Anything else with MS? Darla talked about all of a sudden they would drop things. So they're not able to grasp. They may have just paralysis on one side, this limb, maybe something else, or a foot drop. But it can move around and it'll exacerbate. We talked about it. It'll get better and then get worse again. Or, we had the different stages of how it got better and worse. Okay? All right. Back to the spinal cord injury. All right, Rob, this one's yours to read.
Let's see here. A patient with a spinal cord injury at C5 and C6 reports a sudden severe headache. The patient is flushed. Vital signs include a blood pressure of 190/100 and heart rate of 52 beats a minute. What is the priority nursing intervention?
Okay. So sudden severe headache. Blood pressure's high. Heart rate's a little bit lower. Okay. We've got A, call the doctor. B, put them in a sitting position. C, check the patient for fecal impaction. I wouldn't go with that poopy answer at all. D, check the urinary catheter for kinks or obstruction. Well, so that's the same thing we're thinking about. L5. We're talking C5, C6. What's our answer for this? What would you want to do? What does it give us as the answer on the computer? B. Sitting him up, and then immediately we call the healthcare provider. So I still like A, but why are we going to sit him up? We talked about this disease. It's actually a syndrome where they can go downhill very quickly.
It says
Autonomic
Dysreflexia.
Okay, and this is the one that all of a sudden they've got all this pressure. They can't bowel, bladder function, and anything tight you want to let go around their abdomen. But get them up in a sitting position will help, and then also get the position called sitting position for Autonomic Dysreflexia. I do have the medical emergency. Let's talk about Autonomic Dysreflexia for a second. There's a little booklet if you guys would like to look at it. You're welcome to. These are very helpful for the patients. But I'm going to go ahead if you want to write these down to remember them. The warning signs for Autonomic Dysreflexia. Fast, major increase in blood pressure. And it goes 20 to 40 millimeters up, the mercury up. Systolic is higher than usual. They have a pounding headache, heavy sweating. Okay, so there's that headache. Patient is flushed or reddened skinned. They have goosebumps, blurry vision, or seeing spots. They can get a stuffy nose, anxiety, or jitters. They can get a tightness in their chest, heart flutters, or trouble breathing. Okay? So that's why, they're having trouble breathing, if they're getting anxious. One of the first things when somebody's anxious, if you can loosen whatever it is, maybe do the bra in the back, or take off a jacket, anything, as far as if somebody's getting really anxious too. But autonomic dysreflexia. Okay? So it goes from a spinal cord injury. This little book is helpful. Why don't we just pass this around? Things that they have in a kit for them. They have a catheter and supplies. They have things to take care of the blood pressure, but if they can get all that pressure off, it'll make a difference. Mike's doing self-cath. I'm going to pass that around. Actually, thought I had a second one. No, it's down in my bag. Okay, that is the end of this one. All right. What kind of questions do we have on spinal cords for me? Lower back pain today. When is the neuro review this Friday? What time? Okay. Well, let's see here. If I go back to what we've already done, what can you remember about Alzheimer's? It's more common in women. Over age 65. It's 1 in 10 people there. Okay. What kind of things help them the most as far as their care? Structure. That routine. Keeping the hairbrush in the same spot. Don't move the furniture on them. Don't take them to a different thing. What about mirrors? Are mirrors a good thing with people with Alzheimer's? Not necessarily, because they may look in the mirror and see a total stranger. They don't remember themselves looking like that, and they think another person is there. Something to think about. Let's see here. Who's it also hard on besides the patient with Alzheimer's? The caregiver, absolutely. Is there a drug that cures Alzheimer's? Do we want to let our families know that? Yeah. We do not. We want to make sure that they know there's things that can help it from getting worse, but it's not ever going to get better. What kind of drugs? Aricept, Rimonal, and Namenda are some of them. Okay. What about Parkinson's disease? Males, yep. Young and middle age. They're usually older because the young and middle age ones, we had the video on Huntington's disease, right? And that's usually our younger and middle age. But as far as Parkinson's, over 40 years, why do we think it's a lot in men as well? We talked about exposure to pesticides, herbicides, industrial chemicals. Okay, what happens with that Parkinson's patient? Tremors, maybe one-sided, it gets worse, it gets two-sided. And when you're trying to get them up and they're sitting in a chair, and it takes them forever. If you've ever had one of these patients, it may take up to 5 minutes to where you can get them to be able to stand up. I mean, it's forever. And even a lot of times they still won't get their back straight. Okay, so it takes a long, long time to get them. What is lost from the brain in Parkinson's? Dopamine. Okay, the dopamine lost to the brain. What kind of face do they get? Mask-like, freezing, Let's see. Later on, they have trouble chewing and swallowing. Very difficult. Cinnamon, Compton are a lot of drugs. They're very common to use. And they talked about a vacation from drug therapy, the drug holiday. And what is that? When they get back to the corner and nothing's working for that patient, they go ahead and they can take them off everything for 10 days. And then they restart, but with certain ones to see if that one makes a difference. Okay, feel good about those. All right, I think it's time to let you have a break for lunch. That sound okay? And then we'll start back this afternoon.